Thank you for that kind introduction. And I welcome you to the second day of the deliberations here today. And it looks like a full house again today. I'm going to speak on telemedicine, which is probably some of you might wonder what role does it have to play in medical tourism. And yesterday, one of the most important questions posed was how do we do pre and post care of a patient who probably comes to India, and telemedicine might be one of the answers. We could, using telemedicine, review the patient charts, guide them about the paperwork needed to come to India, and definitely in patients who have had major surgeries, such as in the field of organ transplant or cancer therapy. They can be guided using telemedicine. We are world pioneers in telemedicine in dialysis, so I might focus a little bit on that, but we have used it for other indications also. So I will let you know, give you a snapshot of what is possible, and definitely telemedicine is capable of running dialysis centers anywhere in the world, because we are getting real-time situational imagery coming from patients, and all a dialysis unit needs is a clinic which has got internet connectivity, which may or may not be extremely good, but we are able to, using advanced technology, even with moderately fast internet connectivity, we can still see the patient, and I will show you examples of how we have done that. We have done live workshops in places like, for example, in 2014 in Madrid at the International Society of Dialysis, we did a live demo. On the screen was one of our patients from Hyderabad doing his treatment, being on the podium and having interaction with the audience there in Madrid, Spain. So anything is possible. So I'm going to talk about the impact of telemedicine. These are some common terminologies used. I won't go into details, but telemedicine, telehealth is probably this, and mHealth, the third one there, fourth one there, are almost the same. It's a use of medical information. Basically, we are talking of medical information from one side to another via electronics communication. And the important thing is the transmission can be asynchronous, which is you store the information, which could be vital data or imagery, and then at your convenience, you access it both ways, the patient or the doctor, and then you respond to that. Whereas synchronous, which is what I am talking of, a real-time encounter, where it's interactive. And there are a lot of regulations involved, such as HIPAA. I'll briefly touch upon those things, where you have to take care of the patient's privacy. Privacy Act has become and is going to be very important in determining that patient privacy is maintained. And though presently it is there in United States, Canada, Australia, New Zealand, and many developed countries, it is yet to come to India and Africa. But this is going to be regulated, so we need to take care of that. I'll come to that. So basically, these are the four words: telemedicine, telehealth, mHealth. mHealth is using mobile devices for the same purpose. Asynchronous is not at the same time. There is a stored device and storing device where you access patient information. And synchronous, which is probably very much more relevant to health tourism, would be the important way of going forward. This is the basic schemata of what we do. So you have a Android or a iOS platform down there, which is either an iPad or a tablet, and it can give bi-directional real-time exchange of communication between patient, medical, and their medical caregivers. The patient is at a remote site, either in a clinic in Africa, or in their homes, and with broadband 2G, 3G, or 4G other connectivity, can have access to the doctors, nurse caregivers, nutritionist, social worker, and get all their problems sorted out using telemedicine. We were just discussing, me and Dr. Constantine, about integrated approach to towards telemedicine. Most of the chronic diseases have got probably 90% of the data are similar, like in hypertension, diabetes, chronic kidney disease, and cardiovascular diseases. So this paper by Finney et al., they actually looked at 72 telemedicine applications, which were well-done studies, and the areas included by congestive heart failure, hypertension, diabetes, and respiratory diseases, mainly COPD, and chronic kidney disease. CKD stands for chronic disease. There were 25 papers in CHF, 9 in hypertension, 20 in diabetes, 12 in respiratory disease. This is a landmark paper, and 6 in CKD, including our application, was analyzed. And their analysis revealed that the application shared many common functionalities. It also revealed that each application relied on its own implementation of these common functionalities and unnecessary duplication of portions of the implementation. The implementation of, the bottom line, the implementation of a common data transmission system and a single integrated data processing and archiving platform would provide a unified environment for covering several chronic diseases and comorbidities. So what I'm saying is, instead of having one for each disease, you can have one which will cover all diseases, and probably 90% of the application can be used for each particular, say, for congestive heart failure. The remaining 10% might be a little bit specific to some other disease. But most of them will be covered by a single integrated platform. I'm straight away going to what is called the HIPAA, which is the use of computer device to exchange personal health information triggers the HIPAA security rule. According to the Department of Health and Human Services of the United States of America, the HIPAA security rule outlines national standards designed to protect individuals' electronic information protected, health information protected, is called EPHI, that is created, received, used, or maintained by a covered entity. Unauthorized disclosure of PHI is a risk and carries punitive damages. Some of the damages can be as high as $500,000. Inadvertent, probably you can explain why it happened, why it didn't happen. That's why I'm not very much supportive of using smartphones as for electronic health records, because they have their own risk. I'll come to that. The PHI is a risk because devices store data on the device itself in one of two ways: within the computer, in the onboard memory, or within the SIM card, if it is a phone or memory chip. The devices used to exchange EPHI retain a record of the data on the device. In addition, devices may not restrict user access to data through the use of encryption software or authentication features. Therefore, we need encrypted data. There are 3 important steps which I'll come to. The covered entity must be aware of the unique security risk inherent in using devices to exchange PHI. Just imagine, I think those who are from India probably know about it, but outside India, probably, we have what is called the unique identification document called Aadhaar card in India. And there was a small demonstration about a week back where a person showed how easy it was to hack it. And you get into, luckily Aadhaar card does not have very detailed information about the person. But imagine how easy it would be to hack into the records if telemedicine is going to be practiced without the HIPAA rules. You can access patients' HIV status, some important health records which can be misused. Especially, I would say, politicians can have problems, and patients can have problems. So these are important aspects to be addressed, especially in the future in the countries from where we come from, like from India and Africa. We will already, the Parliament is discussing the security aspects of electronic health records and trying to implement both in medical devices and the transmission of electronic records. So the HIPAA Privacy regulations require healthcare providers and organizations as well as their business associates to develop and follow procedures that ensure the confidentiality and security of protected health information. This applies to all forms of PHI, including paper, oral, or electronic. Only minimum health information necessary to conduct business is to be used or shared. Unless you have HIPAA-compliant platforms, you are very restricted. So any software that is developed for telemedicine should, right from the beginning, conform to HIPAA standards so that at a later date when it's implemented in your country or our country, it should be compliant and we can go forward. So this is what I was talking of. The full form is Health Information Technology for Economic and Clinical Health Act. This is the act that came later, the High-Tech Act, sorry. The one was the previous one, the HIPAA. So the United States enacted this. The original one was enacted about 10 years before that. In 2009, the High-Tech Act came on, where it assuaged some of the doubts that the medical professionals had. And it's now also the fact that you are providing services, but you're not getting reimbursed for that. And a law is coming in where it will be made compulsory that telemedicine is used for medical care. It is, and maintenance of electronic health records. It will become compulsory because it's been proven that it improves patient care, it brings down cost of patient care. So these two important factors are very, very, and also helps the patient in decision making, which is going to be the future. So the electronic health record adoption in the healthcare system as a critical national goal and incentivized electronic health record adoption. So the physicians will get paid, a modality is being worked out whereby the physicians have incentivized properly formulated reimbursement policy. So high-tech and HIPAA are separate and unrelated, but they do reinforce each other in certain ways. And high-tech has cleared a lot of doubts that existed in the medical professionals in that group, in the professional group. And high-tech has helped them now to go ahead with the electronic health records and transmission, basically telemedicine. PIPEDA is the, PIPED Act is the one equivalent in Canada. Similarly, we have other things in Australia. And so much so that in the US now, you have almost the entire industry making HIPAA accessories. Blackout screen images where when someone is viewing a record, especially while you're flying or you are sitting in the office and the guy next to you who's not supposed to access that information is trying to peep. What the screen basically does is it covers the screen in such a way that only the person right in front of the screen can see what is on the display. Anybody on the side cannot see it. So from that angle, it prevents the screen being viewed from prying eyes from reading your screen while keeping a crystal clear screen image. It eliminates off-angle screen viewing. You have shredders, which are HIPAA compliant. You have toolkits in CD or DVD formats giving you all the, and then you have got the remote data wiping system. Suppose your device is lost. You have a remote data wiping system so that all the patient data is wiped off so that it can't be misused. So there's a whole lot of store available in the store or on Amazon, even Amazon, which are HIPAA compliant. Mobile phones are particularly vulnerable. I told you I'm not very confident about, this is what the general consensus is. Mobile phones are particularly vulnerable to loss and theft because of their small size and portability. The most common form of security breach is theft of mobile devices. And imagine if it has access to all your patient records. It's going to be a major security breach, which, if not justified on proper grounds, is eligible for seek of damages. So a recent survey of 600 US hospital executives, physicians, organizations, health insurance, pharmaceutical, life science companies found that theft occurred for 66% of reported data breaches over the past 2 years. Mobile devices are typically small, light, and highly visible to would-be thieves looking for an opportunity to take a phone left behind in public spaces such as a restaurant. So I would discourage a smartphone is a bad idea for remote monitoring. The device need not be, a medical records carrying device need not be carried 24/7 on person, which most people do with mobile phones because of risk of thefts. It's probably not advisable. And close to none have any antivirus on them. And the device in patient home, which I suggest minimum should be an iPad or a tablet. iPad mini is also okay. The screen size also, though not very strictly governed by HIPAA rules, is very important in data transmission, because you can't have a very small screen and enter your data, because I think a lot of typos come in if you're using the keyboard of the mobile phone. So we need the device in patient home only, where patient data is transmitted to the hospital or the doctor. And the screen size, as I said, is too small, and most of them are almost, I don't think anyone here has an antivirus installed in their phones. I doubt very much. I don't have. I don't need to, I think, but we need to if you're going to use it for patient data transmission. So these are the 3 steps. Authentication. Mobile devices users do not tend to enter passwords or provide biometric identification to access information. I'm not talking of the thumbprint use and iris usage. That is only to unlock the whatever the screen of the mobile phone. That's not what I'm talking of. This is authentication this is for information stored on the mobile device. The lack of authentication on mobile devices presents a risk that any user of the device could access the records. Encryption. Typically data stored on personal mobile device not encrypted, thus records stored on a mobile device could be retrieved and shared by anyone. And the Wi-Fi connection is something which we very commonly use while we are going to a hotspot or to hotels or restaurants, and that is very unhealthy practice as far as if your smartphone has patient data. So I would not, so maybe VPN, the virtual private networking, is probably the only one to a certain extent. As Anita previously said, WhatsApp is encrypted, but we are really not sure what happens and what's going to happen in the future. And another thing is the personal versus the employer-issued phones. Most people never use the employer-issued phones, and the personal phones are used. And then you have the Amazon and Flipkart in India, the sales, where you return your old mobile and you get a new mobile. And people do not know how to erase the data. So that's a big risk again. Now coming to specifics of what we are doing, this is a busy hemodialysis center we run. We also have a chain of dialysis centers. Patients can live on dialysis indefinitely. Transplantation is not the only answer. Look at this lady. She's been with us for almost, not 20, now 30 years. She's probably the longest surviving hemodialysis patient in India. And she had a carcinoma colon. She survived that about 15 years back. She had ischemic heart disease and had bypass surgery, survived that, and she's still going strong on dialysis. Now, these patients can be all over the country or outside the country, and they need to be monitored. Basically, they're very stable patients otherwise. This is basically because people don't know the basics of what dialysis is. You basically have what is called AV fistula, where the vein and the artery are joined together, and a needle is put in, the blood is taken out and purified using the machine. It's just called hemodialysis. This can be done either at home or in a standalone clinic or in a hospital or in the ICU. This is hemodialysis done typically thrice weekly for about 3 to 4 hours. And this is life-saving. I can tell you one thing, the one organ failure which can be treated indefinitely without a transplant is the kidney. You can have end-stage kidney disease and still have the patient living normally, as almost normally, doing dialysis, either what is called hemodialysis or peritoneal dialysis. So actually, kidney transplantation is not an emergency surgery, it's an elective surgery. You prepare the patient, and then you have the donor who's fully worked up, and then you do the transplantation, unlike liver transplantation or heart transplantation, where if you don't do a transplant within a set period of time, the patient dies. Whenever I go from my home to the hospital, it takes about 40 minutes. So I sit using this and use FaceTime, though FaceTime is not HIPAA secure. This is for hemodialysis patients. You can see the hemodialysis patient there, and you can see me. She's seeing me like that, and I see her like that, and I do my the peripheral clinic rounds by the time I reach home. So this is how one of the simple ways of doing telemedicine. This is peritoneal dialysis, where patient can perform the treatment at home. You put in fluid into the patient's abdomen and take it out after about 6 to 8 hours. Do it 3 times a day. You can do it using a machine also. And this is a very good alternative to hemodialysis. And you can use it by, in the night when the patient goes to bed, instead of doing those exchanges, you can use this machine. And our recent work, one of the biggest series in the world, published in Blood Purification International Journal, coming from Switzerland, where we started this treatment straight away on the day the patient presented to us to the hospital. So this machine can do the treatment instead of doing it 3 times, as in the, like this. You, instead of that, just connect, go to bed, connect yourself to the machine, and then get up in the morning, disconnect, and you're a normal person. You can go about your normal activities. That machine can be accessed at a remote center using telemedicine, and you can get the data of the patient using this share source technology. And this is how we do the regular PD patient monitoring. I will not, there is actually, the important thing is 1 to 13 hand-holding step. One is, presently we use the iOS tablet because this is more prevalent in India. And when in the PD unit, we have what is called a web module, which can be accessed using the laptop or the desktop. And this is how a screen looks, the iPad screen. You can see the patient there, patient data, and there are 13 steps to guide the patient through. The patient is already trained. Once in a month, we make sure that the patient is doing things properly. So we get this on. The patient connects to us. Once a month, they do this. Or if there is any issue that the patient wants to connect us, or we are finding some disturbing data coming from the patient, we monitor the patient and ask the patient to come online. So it is, as I said, you can see guided process to improve compliance and avoid mistakes, clearly guided PD exchange process for both manual and automated PD. You can, this data is transmitted to the PD unit. The PD unit or the nephrologist has access to all their patients, whereas the patient has got a HIPAA secure access only for their data. So a PD exchange, as I said, 3 times if they are doing, their vitals, their lab, all data is included. At the touch of a button, if you are doing research, you can get all information about this. And there is instead of, what we do when we do a Skype, we actually put the video off and put the audio on. So that connectivity is not a problem. Here we have the reverse. We have the video on, and audio, we have what is called the web chat. So you can see me there at the right-hand corner, and the left side is the patient. And we have the web chat. Good evening, doctor. Good evening, Mr. Minhaz. I was about to start the exchange, and I was feeling very cold. He has got a complaint. Okay, you warm the bag and using a heater. So this is the information, two-way information, which is synchronous, which is going on. You can see that. And we also have the most important aspect of our this thing is the software is the cameras. You can have picture of what is called exit site. Exit site is where the PD catheter comes out of the tummy. You have the second one, the bag, one with pedal edema, which is the swelling in the legs, and then any other additional photograph. And then we have 25-second clips, any number of clips, but we restrict it to 25 seconds, and the next clip comes so that we can keep it synchronous. Otherwise, the size of the file becomes too much. And this is stored both in the horizontal pattern and the vertical pattern, by which I mean when the patient has started the treatment, you have all the data in a horizontal line, including their bag, their exit site, and everything. And the vertical data is whenever we do one more round of interaction, or when they have a problem. So even if the patient has started the treatment 10 years back, you have the data there anytime you can access. So what happened in April 2014, and you have got the data there, everything. That is all in a vertical disposition, and you get the horizontal data of that date also, right from the beginning when the patient started the treatment. And this is a new thing that, additionally new thing that we started, that the bag fluid that comes out, if we can see it, even if the patient is on Mount Everest or on an Atlantic cruise, you get a picture of this and you can read the fonts. That means that the patient is not having any infection. Infection is one of the problems with peritoneal dialysis, and we have devised this for the first time in the world. The software itself, but this particular aspect, we have what is called a zoom tool. You can see the exit site there. Exit site is where the catheter comes out. You can see it magnified. So this is a movable zoom tool. You can see the patient's this can be applied to any specialty. As I said, integrated approach is what we are looking at. And you can allot the PD nurse to each patient, and they know their duties that day. This is how, and then we get a roundup of how many patients are doing well, which patient I need to see, the physician review page. It actually comes as a pie chart. A green pie chart is a very nice chart, which means that all my patients are doing well. If they're not doing well, I'll get a red-colored pie out of it, which means I have to address these patients. And within 20 minutes, I can take care of them, and then it neatly turns out to be a green, fully satisfied patient, green pie cake, which means that all my patients are doing well. Left side is just to give you an idea, just like you are keying in for some credit cards. This is the login page, HIPAA secure login page. Nurse, normally the international protocol or guidelines is that one nurse can handle 20 patients. But with this system, we can handle 100 patients, which reduces the cost to the PD unit. And this is one important aspect called quality of life SF36 tool, which patient fills in about 2 minutes after doing every round, whenever they are in touch with us. And you can see suddenly that the patient is not doing well. You can see in that histograms there that the patient quality of life is coming down. So you can ask the patient to come, or you can completely review the chart, make the necessary changes, and within a month you can start seeing that the patient is coming back to normal. The very nice, very, very useful device, SF36, which has got a physical and mental aspect. You can see that the physical health and mental health both are improving. This we have published numerous publications, and there have been counter-publication citations. One of the most cited paper in the field of chronic kidney disease. This is an invited editorial I wrote in the Peritoneal Dialysis International. Numerous papers all over. And then we have one of the universities in US, the University of Virginia Medical System, did a pilot study. They were so interested. They asked for our software, and they did it in their patients, and we're very happy. Professor Mitch is the person who did that, and he's published it, a pilot study of a tablet computer. You can see that. This is the original study we did way back in 2008, 2012. The study was started in 2008. And the Harvard Business Review has reviewed our application and wrote glowing reports of that. And the cost savings have been like $5,000 per patient. And if you see purchasing power parity, it is a phenomenal amount of per patient per annum saving because of the software. We are now in the process of doing a study, a dual center study with a leading hospital in Brisbane, in Australia. It's called the Princess Alexandra Hospital, and we are in the process of starting a big study to evaluate these softwares. So this is the Virginia study, which came in blood purification, which validated the software as being. And I'm part of the 0/25 initiative of the International Society of Nephrology, which means by 2025, no patient should die of end-stage renal disease or acute kidney injury because of lack of dialysis services. And Sundarbans is part of Bangladesh and India, has got many small pockets of islands where people don't have electricity. And I visited one of my patients who was taking treatment for me and connected by telemedicine. You can see how his computer was being charged. It was a solar, that's me there in Sundarbans, in that, this is in the northeastern part of India. I think you from Bangladesh know very well. It's famous for the Bengal tiger and for a lot of wildlife. And the software, I mean, their computer is being charged by the solar panel there, his mobile phone, and he's in touch with me for his treatment using telemedicine. So technically, a patient can be in a yacht in the middle of Atlantic. They can be on the top of Mount Everest. As long as they are satellite connected, they can be in touch for their treatment. There's actually Tony Watt from UK who climbed Mount Everest and did one treatment of his dialysis there right on top of Mount Everest. A very rarely known fact. There are people, you will be surprised to know, a patient with CKD on dialysis came third in the Olympics, the Summer Olympics, in 110 meters hurdles. Can you believe this? And the fastest person in the World Transplant Games runs faster than the Indian record for 100 meters. So they are that fit. 10.4 seconds is the timing for 100 meters. You from Africa know much more about athletics than we Indians because you are really top of the line in track and field. And 10.4 is the best timing for 100 meters for the transplant games. Our record is also 10.45. So they're faster than Indians, the fastest Indian. So what Africa needs, India can provide using telemedicine, especially for dialysis care, setting up dialysis units, pre and post care of patients who have had treatments in India using these kind of softwares. And world leaders in dialysis therapy, you can see me there sitting. We keep deliberating on issues like this. One of the issues was telemedicine and many factors. And we really feel that telemedicine, as we practice is, just as they say, objects in the rear view mirror are closer and larger than they appear. I feel telemedicine is closer and larger than we think it is. It is going to be in everybody's daily practice in the coming future. So as I say, telemedicine for all and everyone. Thank you very much.
Thank you, Dr. Nayak, for the wonderful insights on telemedicine. Now we take a short break for tea and we gather back in 10 minutes. Thank you.